As I mentioned, the test becomes increasingly prevalent as the disease progresses. So it goes from about 10 to 12% in the frontline setting to about twice that in the post-ABI-ENZA setting. This is really where the test probably has the greatest utility in preventing the switch from ABI to ENZA and from ENZA to ABI. In the frontline setting, as I mentioned, most patients actually do respond to this therapy, meaning that there's less clinical utility for doing a test before a patient has ever had ABI or ENZA. The same would be true of the Hopkins QIAGEN assay, where the prevalence seems to increase over time and with disease progression. And so if you're a clinician faced with a patient who's progressing on ABI and the choice between enzalutamide and another alternative therapy such as a taxane or radium, this test may help, along with other clinical features of that patient, to decide what the next appropriate step may be. The groups of patients are only right now castration-resistant disease. We tend not to see AR-V7 as a positive test in hormone-sensitive disease, and we tend not to see circulating tumor cells very much in patients without metastatic disease. So it's really only going to be indicated for patients with metastatic disease in patients who have failed frontline hormonal therapy. And that's where the clinical decision really has an unmet need. And we're trying to develop novel agents that may benefit these patients directly, whether that's an immune therapy or a DNA repair agent or a combination approach. This is where the field is moving.
When we were looking at the AR-V7 in the first line setting, in patients who were just progressing, the frequency was very low, under 5%. So there's no point really in ordering a test when you have a high response rate drug and a low frequency of the alteration. Get into the second line, you got about a 20% rate. And we're able to show that in patients, in our first trial, we didn't use the test result. We didn't know the test result. We didn't use the test result to make a decision. It was basically the physician's choice. And we found that when the AR-V7, using a protein test, was in the nucleus of the cell, those patients did not respond to our hormonal agents. In contrast, they did just respond to a taxane, docetaxel or cabazitaxel. And then ultimately, when we completed the analysis and looked at other factors that might influence survival, we were able to show what's called a therapy interaction, and that those patients had an improved survival by getting a taxane at that point in time if the AR-V7 was identified. This is still it's more than a preliminary result, but it has to be validated, which means it has to be shown independently in other tests. I believe Dr. Antonarakis did speak about a study that's being conducted by Dr. Armstrong from Duke University, where he's comparing different AR-V7 tests in those contexts of first decision, second decision, third decision. Those results will hopefully be available within the next year.
So right now, a patient would still get frontline abiraterone or enzalutamide, irrespective of the results of this test. So it's generally not going to be recommended to do this test before a patient's ever seen those drugs. However, many patients will then progress on these drugs within 1 to 3 years of their therapy being started. In those patients, many physicians right now in the United States are switching from one to the other. However, those patients are most unlikely to benefit. So trying to find a test that will allow the patient more optimal care, to get a taxane, to get a clinical trial, to get some combination approach, maybe a novel hormonal therapy and a novel immunotherapy, radium-223 if they have bone-predominant disease. This is where the test can be useful, basically in preventing the use of ineffective therapies.